Andrea,
Okay.
what's our theme song for the mailbag?
Oh, we get letters, loads of letters. We get letters, letters, letters. We get letters.
Okay, I'm sorry I asked. Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. Good to see
Hello.
you two. Hi.
Great to be here.
All right, on the show this week, it's another edition of Mailbag. We have emails from all over the world from amazing people who want to talk about their metabolic health. So before we waste too much time, let's jump right in. Lisa has emailed, "Hi, Dr. Cooper, Mark, and Andrea. I love listening to the Fat Science podcast. It makes me feel heard and seen. It was truly eye-opening for me. However, I'm a bit confused about Dr. Cooper's approach to the concept of starvation mode and the idea that eating too little significantly slows down our metabolism. I often hear and read that its impact isn't as significant as Dr. Cooper claims, that our metabolism can slow down, but not to the extent it stops weight loss. I haven't been able to find scientific research supporting this theory, only studies suggesting the opposite, that starvation mode is largely a myth. That being said, Dr. Cooper's explanation makes more sense to me than the alternative theory. Why isn't this theory supported by more doctors and scientists, and where can I find research that backs it up? Thank you in advance. Kind regards, Lisa from Belgium." Dr. Cooper, take it away.
I love this question because there's so many aspects of this question to talk about, but I'm trying to keep it not too long. But when you look at how does the metabolism actually work, well, it's pretty obvious that if you are depriving yourself and that's altering the signals that say that we're secure and enhancing the signals that say that we're starving in the body, it's pretty obvious that that would slow your metabolism down, because that's the whole purpose of our metabolic feedback loop, is to gauge our food supply and the sense of nutrition security in order to help conserve energy at times of famine. So that's the purpose of the metabolic feedback loop. So when you think of that, it's just only logical that if we get into that situation, that our metabolism would slow. And once it slows, it becomes harder and harder to lose weight on a diet. Diets start by restricting the caloric intake. And then people notice, now I'm not losing as much weight, so I have to restrict it more. And that's because their metabolism is slowing down. And so, but it gets to a point where you can't lower your caloric intake enough to actually see any more weight loss because the metabolism has just adapted to that. And so that's where people kind of get into these food prisons and situations where they're just super frustrated because no matter what they do, they're gaining weight at that point. So I think that from experience, people know this is true because just like Andrea has been on all these diets, so many people, there's not one patient that comes into our clinic that hasn't already done all the diets, all the exercise, done everything they're supposed to, quote, be doing multiple times. And it hasn't led to any meaningful, resolution of their excess weight issue. So I think just from experience, it's kind of obvious. But if you want to dig into the research is there. And there are studies, even going back, I'm trying to think of when some of the first studies were done that showed this, but I think it was the 1940s, actually. And there were things even before that in hospital settings where they put people on diets and they were puzzled with why they weren't losing weight according to the calculations that they should be losing at. And that was mainly thought to be due to this biologic adaptation. So once we learn more about the hormones, we can understand the mechanism behind that. But there have been studies. What's really hard is to do these long-term studies with dieters on the metabolic hormones. But there have been some. The longest term one I saw was about 18 months, where people were put on like a 12-week standard diet with exercise. Their hormones of metabolism were measured pre-diet and then going out at regular intervals for 18 months after the diet was over. And what it showed was a long-term, long-lasting imprint of the diet at 18 months, where the security signals, which are, like, as we always describe, like leptin, which was measured, was still suppressed at 18 months out from the diet, way below where it should be. So that meant the body fat was literally trying to hide from the rest of the body in kind of a defensive mode. And at the same time, ghrelin, nicknamed the hunger hormone, was elevated going out 18 months compared to the pre-diet stage. And so that was extremely high. And other markers, similar markers. So you saw the famine signals were all elevated. The security signals were all suppressed. And some of them had built up dysfunction over that 18-month period. So it wasn't getting better, basically. So from that one diet, it left this lasting imprint. And these were not previous dieters. So it really has been shown. There's the Biggest Loser study that people are aware of too, where 6 years later, the metabolic rate was slowed by, I think it was like 600 calories a day. Don't quote me on that. I haven't looked at the data recently again, fairly recently. But it shows long-term imprint of metabolic slowing caused by deprivation, caloric deprivation, underfueled exercise. So that is out there, and maybe in the show notes we'll post a couple of those studies here so that you can see them. And I just think it's underplayed in our medical community and the research community, mainly I think because of biases and also because of the diet industry that had such a big hold monetarily on the population. I think that it was beneficial to a lot of people to just blame patients and blame people for not dieting well enough, and that being the cause, instead of looking at the metabolic slowing that happens as an adaptation to diets.
All right. Lisa from Belgium, appreciate the question. Thank you.
It's from Michelle. Hello, I love your show. I started listening in February. I found it to be informative and transformative. Thank you for sharing your knowledge and personal experiences with the world. I've tried to look through the list of topics to find information on weight loss plateaus. I don't see any episodes about it. If you've talked about it, can you let me know the title or number of the episode? If you've not talked about it, please do. Here are my questions. Why do plateaus happen? How long do they last? And is there anything one can do to break the plateau? Thanks for your consideration. Michelle from Costa Mesa, California.
Well, plateaus, one thing you want to think about with plateaus is what was going on before that. You know that we're not advocating diets. So that would be number one, because we just talked about in the last question about the biologic adaptation that occurs with diets. And that will happen even when you're on medications. Eventually, your metabolism can slow due to the deprivation cycle. That would be what it does when you're on a diet, basically. And so if that's one of the areas that's potentially contributing to the plateau, you've got to focus on nutrition and eating regularly, making sure your body security signals are strong enough to not cancel out the effects of your pharmacologic approach there. So that's one thing to think about. But the other is some people think that they're in a plateau when it's just a normal process because, when people are being treated pharmacologically for excess weight, there's a trajectory of movement of weight loss or weight gain. And so what's good to look at is what's your baseline before you start medication? Are you gaining weight? Are you stable? Are you already losing weight just naturally? Like, what is really the natural status? Because say you're gaining weight initially before you start medication, a plateau or somewhere where you're maintaining weight could be a sign of progress. That could be that the medication is effective, and that's really good. So that would be different than somebody who, had a stable weight and then they're on the pharmacology and nothing's really happening. That's a different situation. So you want to look at these plateaus and what kind of setting it's in, and you want to look at what the lifestyle is like, the sleep, all those healthy metabolic activities that we always recommend. Is that really happening? Because that's still really important. And I feel like nutrition foundation is probably the most important thing whether or not you're on medication for your metabolic health. The nutrition foundation is so important. But then lab work. What does the lab work say? Is there something, a glitch there that's not being addressed well enough by the current pharmacologic approach? And so your provider will look at that and maybe make adjustments, maybe dose adjustments, maybe medication adjustments. So, but it's normal. It's normal.
And sometimes expectations need to be changed.
And that's true.
Patience, we just did an episode about patience. It takes time. And sometimes the plateau is something that, it's a work in progress. And we're all anxious. We all want everything to happen in an instant, and it doesn't.
Yeah. One thing we do in our clinic is we calculate like the weight loss rates, even though we always say it's not about weight loss, but of course we're concerned with that. And
it's a metric.
It is a metric. And so we calculate it. So we take the time frame between the last visit and the current visit, the percent of body weight loss then over that time frame, and we convert it to an annual weight loss rate. That enables you to see the big picture of what's really happening. Because some people will say, I'm in a plateau, and we'll say, no, you're not actually, because you lost maybe weight rapidly, which your body realized it was too rapid. So it stopped it for a while to try to balance it out. And then, it will continue down, and there's no need to change a medication. So you kind of really need to look at these metrics.
Thinking big picture as opposed to, I didn't lose weight this week.
Yeah, and the idea that a plateau, Dr. Cooper, as you said, is oftentimes a sign of success. When I first came to you, I was on an upward trajectory in every category.
Yes.
And the fact that leveled off was a huge improvement to what was going on.
Yeah, it's really important to see it that way.
Great question, Michelle from Costa Mesa. Appreciate that. Next, we're going to go Kate in the lovely state of Vermont. If you've never been to Vermont in the fall, oh my gosh, it's like a postcard everywhere you look. Okay, let's get to the question. She says, hi all, I'm continuing to absolutely love this podcast. I learn so much each week, and I often go back to re-listen to episodes so that I can increase my knowledge. I've been a patient of Dr. Cooper for about 3.5 years. I'm amazed at the positive changes in my health. I do have a question about metabolic health and its role in depression, dementia, and Alzheimer's. With a family history of all three of these, I'd love for you to do a deep dive on this topic. Example, information on the science behind the diseases, what can be done to help prevent or lessen the risk. So Kate from Vermont, I'm not sure we have time to do a deep dive here, but I'd love, Dr. Cooper, for you to hit on this, and maybe we can do a full episode down the road on this. Kate, thank you.
Yeah, I think this would be a great full episode. But, our mental and cognitive function is just so dependent on our metabolism and on stable blood sugar levels, glucose levels, and glucose utilization by the brain. The brain really likes glucose in order to perform all of its tasks, basically. So that's where the nickname for Alzheimer's became type 3 diabetes. I don't know if you've heard of that, but it's been referred to as type 3 diabetes, Alzheimer's disease, because it really has to do with the risk increasing with problems with glucose uptake and utilization by the brain. So if the brain cannot access glucose adequately or use it properly, it starts to set the stage for all kinds of potential cognitive impairments, that range from Alzheimer's to just general dementia. Multi-infarct dementia is a common type of dementia that comes from vascular disease, and so metabolic dysfunction plays a big role in the risk for vascular disease throughout the body. So there's a huge connection with metabolic health and predisposition for some of those conditions. One of the things that I think is one of the biggest risk factors that I've seen in the literature for dementia and potentially Alzheimer's is, and definitely mood, is hypoglycemia. So low blood sugar reactions, because again, the brain really needs glucose in order to function properly. And it's literally potentially injured from low blood sugar reactions if they're really severe and if they're recurrent. And so a lot of studies have mentioned that correcting hypoglycemia problems by midlife is really beneficial for preventing increased risk of dementia and cognitive decline with aging as well. So I think focusing on stable glucose levels and just an overall healthy metabolism, if you have metabolic syndrome, reducing those disease risks that affect your vascular health, it's just also important. And so, and unfortunately, a lot of this runs in families, and you wonder, what part of it is the familial part? Is it the metabolic part that's setting the stage for this? Or is there just an independent risk for dementia that's aside from the metabolic influence? But I think for a lot of people, it really starts with the metabolism.
Wow.
Yeah, I think there's definitely enough for a full episode, Kate, down the road. So appreciate that email. Thank you.
Wow. Interesting. Well, our next letter is from Annie, and she says, "Hello, Dr. Cooper and the Fat Science team. Hello. I'm a big fan of the Fat Science podcast. It's informative, insightful, and has significantly enhanced my understanding of metabolism and health. One topic I'm very curious about but haven't seen discussed yet is the relationship between cannabis and metabolism. Given the increasing popularity and legalization of cannabis, I'd love to hear your scientific perspective on how cannabis use might affect metabolic processes, appetite, insulin sensitivity, and overall health. Would you consider covering this topic in a future episode? Thank you for all the great work you do. I look forward to hearing your insights. Warm regards, Annie." Well, this is a good one.
That is
considering
a good one.
That at least in my neighborhood, every corner it seems has a pot store.
Yeah, same up here in Washington now that it's been legal for quite a while now.
Yeah, and a lot of our patients have used different forms of it for helping
for
with
all different
sleep
things.
and
Topical
Right.
as well as ingestible. I mean, that is interesting. Like, what does it do?
Well, it is interesting. Because I guess, we think about cannabis, there's the different chemical compounds within cannabis. So everyone's familiar with THC, which is like the compound that makes people kind of high. And then there's the CBD, which has been kind of promoted as pain and
Right, for your arthritis and stuff like that.
Right. And so the chemical compounds they have a lot of mixed effects on metabolism. But I think the most important thing to keep in mind is that when we talk about the metabolic pathway, I don't know if people remember any of the science of it that we're talking about. There's the melanocortin pathway in the brain, which sends our messenger signals from our hypothalamus to our pituitary, and then receptors throughout the brain that regulate our energy metabolism, our insulin levels, and our weight set point and all that. And these compounds, CBD and THC, do have some impact in that melanocortin pathway. And THC in particular can stimulate part of the substation that we call the POMC pathway, which is at the pituitary level. And it can partially stimulate that. But then what ends up happening, I don't know if anyone read my book, but I call it like a swinging door, the POMC pathway. Because as it gets stimulated, there's another mechanism that can shut the door. And that is through our beta endorphins that are produced there. Endorphins are like a natural opiate. And so what happens with the THC is it stimulates that door, but then it causes the beta endorphins to increase, the opiates. And the opiates are the component that can turn around and close the door rapidly. So the end result is that while it can stimulate metabolism a little bit, it can also end up shutting down metabolism because of the buildup of the endorphins. So I think that would affect people that are more regular consumers of these products. So occasional, I don't think there would be anything, dramatic happening metabolically, but the regular consumption of those products could turn around and have a negative metabolic effect. Some of our patients really need to take those as a medication, basically, those products, and it helps them a lot. And what's kind of interesting is other metabolic medications that help turn around and prevent that substation, that POMC path from shutting down. If you add that to the THC component, it helps override any of the negative aspect of THC consumption, and it prevents the metabolic glitches that THC could cause. So there's ways around it. If somebody really needed to take a chronic long-term dose, there's ways around it, just like there are ways around it with any psych meds that might interfere, prednisone. You can look at what area they may impact and see if you can do a workaround, basically.
It's a great question. Thank you, Annie. And again, I think that might be enough for a full episode at some point.
I think it's enough for a full episode, actually.
Because it would be fun to dig into some of the studies that have looked at the connection between metabolism and cannabis. Mm-hmm. All right, we're going to move on to a question from Christian. Hi, I am a huge fan of your podcast. I have a question. Do we know what kind of metabolic changes happen after liposuction? Abdomen or other parts? ? Thank you, from Christian. We see these ads on TV all the time, Dr. Cooper, about body sculpting clinics, and they make it sound super easy and super simple. As we've talked about before on the podcast, some things are not so easy and simple, especially the after effects of it. But this is a great question. What happens when you go in and take fat out of the body? Then what happens?
Well, it can definitely cause like a rebound fat gain afterwards. So just to get to the bottom line of the liposuction concern, not all liposuction will do that, but a person can be very vulnerable to, if they go into that with, again, low leptin levels, because if the body fat signals are already weak, then you go into the liposuction. What ends up happening is by removing that body fat, it lowers the leptin further. And
because the fat creates the leptin?
Exactly. The body fat produces leptin as a hormone. And leptin as a hormone messenger is really an informant to the rest of the body that says we weigh enough. And so that's a critical piece of information. And when the level is too low or the brain can't see it, it just assumes that you must be underweight, you must be in a crisis. So going into the procedure already with a weakened leptin or a suppressed leptin level, and then having this body fat removed, I've seen this happen to patients where they came to me after this had happened, but they just got amazing, like incredible amount of rebound weight gain, like insane amount quickly. And so it can really cause problems. And so we caution our patients to be really careful about liposuction. And there are instances where there may be a necessary small amount of liposuction, maybe after like a tremendous amount of weight loss. And if sometimes body fat forms like weird little pockets that are abnormal, and they can also be really uncomfortable, like pulling the center of gravity off. So this is after like tremendous weight loss, and there's maybe skin removal that's going to happen, and there may be like a weird abnormal pocket that has to be removed. That's different if it's something like that. That's more of a medical thing. But I think just blindly going out there and doing the liposuction, it is risky metabolically.
All right, Christian, thank you. Great question. All right, Andrea, who's up next?
We have May. And it says, in a couple of past episodes of Fat Science, it was mentioned that liraglutide was going to be available in generic form in 2024. I wondered if on an upcoming episode you could talk about whether that's happened and how it's now available, as well as what it might mean to switch from Wegovy, Ozempic, or Zepbound Mounjaro, as there are many of us paying out of pocket who might be considering switching for the financial aspect. What does liraglutide do similarly or differently than the other meds? Would it be a safe option to consider switching in order to save money?
Well, it definitely would be a safe option. The only problem is the cost just went up again. So it has been available as a generic, and the cost was really good for a little while with the GoodRx coupon. But we were thinking the cost would go down because there's more competition now with at least three manufacturers of the generic. But suddenly the cost just escalated. And so we did have some patients that were using the coupon, and now it's not the most cost-effective option. But it's a great medicine. It does reduce cardiovascular risk. Also, it's a daily injection instead of the weekly. And it's not as powerful as the max doses of Wegovy or Mounjaro or Zepbound. It's not as as powerful, and it's marketed as Victoza, but it's the exact same drug as Saxenda. So Victoza's for diabetes, so you could compare it to Ozempic or Mounjaro, and Saxenda is quote weight, and that's comparable to Wegovy or Zepbound. But it's not as powerful unless it's at its full weight-related dose, which is much higher than you'll get with the generic coupons and things. So, but for someone on a low dose, it was a good option. Someone who's a good responder on a low dose, it was a great option. But the only problem is the cost went up. So right now, you're better off with the manufacturer programs, with Novo Nordisk or Lilly that have their manufacturer. It's like coupons, but it's also they have a cash pay program. And what's really great is the Novo Nordisk cash pay program applies also to Medicare and Medicaid patients, where a lot of times that group of patients are excluded from using coupons because they're government-sponsored, subsidized insurance. And so they did some kind of a workaround so that it's just a cash price and there's no coupon involved for the Novo Nordisk through their pharmacy. So I think there's some other options. You have to kind of keep dancing around what the best, most cost-effective options really are.
Yeah, so Dr. Cooper, if someone doesn't have the ability to get insurance to cover this stuff, of all the options out there right now, which would be the most cost-effective in the GLP-1 category?
That's a good question. It depends on the dosage that you need for medication right now, whether it's better to go through a Canadian pharmacy where there's some flexibility there, or if you're on the higher doses, it's really better going through the U.S. pharmacies, either directly to Lilly Direct, which is the Lilly pharmacy, or NovoCare, which is the Novo Nordisk pharmacy, going directly to them. And they can set up patients with the best price.
Yeah. And when it comes to the latest cutting-edge developments on the GLP-1 drugs, what's the next big development? Is it the oral medication that they've come out with, or what's next?
The next, I think, that will be coming out would be two different ones that are Novo Nordisk. One is their existing medicine, Rybelsus, is going to come out at some point at a very high dose compared to what it is now, more than double the current high level dose. And it should be a lot more effective than what was available previously. That's a pill, that's a daily pill. And that is a peptide. So it's not the one, that was just run through a trial by Lilly. That's actually a small molecule. The small molecule, it has some advantages because it can be produced at a lower cost and it can be taken with more flexibility at any time of the day. with or without food, so that one is not coming out for a couple of years, the Lilly pill. But this year we should be seeing one from Novo Nordisk, which is a combination of semaglutide, which is the Ozempic, Wegovy, and an amylin analog. Amylin's a different hormone. So if you think of that medicine, it's kind of interesting because the semaglutide, it replicates our GLP-1, which is an informant, again, that says we have enough food supply. Whereas the amylin component is something that kind of has a dual purpose in a way because it is a hormone that goes up when we eat. So it would amplify the food security signals, but it's also a hormone that really helps our leptin signal have more impact from our body fat. So it's a hormone that would act as an informant of both our food supply and our weight being secure. So that's going to be a combination medication, a once a week shot that's coming out. And so I think that one, for certain patients, there's going to be certain patients where that one is going to have a much better impact, even though the clinical trials weren't necessarily super impressive. There are going to be some of those patients that are not responding as well to the others that would respond better to that medication.
Wow. Well, this has been super interesting. If you have a question for Dr. Cooper for the podcast, just send an email to info@diabesityiinstitute.org. You can also directly email her, and it's dr.c@fatsciencepodcast.com. This has been super fun. I learn something every time we get together. And thanks to those of you who are listening all over the world. We appreciate you. Keep in touch and let us know how we can improve the podcast to make it better for you. So thanks for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.